Okay, so we are going to do CMPP exam 7. There are 9 PowerPoints for this exam. This video is just going to focus on the first 4 because they all kind of are grouped together in this like GI part 2. So let's dive right into it. Yeah, there's 580 slides on this exam. All right, so let's dive in. All right, so the first thing we're going to talk about is gastritis and peptic ulcer disease. Okay, so let's go right into gastritis. So the definition, it's simply just the inflammation of the gastric mucosa. It can be chronic or acute. All right. Most of the cases here are going to be from your H. pylori infections. Meds are another big cause here. So NSAIDs, aspirin, steroids. Can be stress as well, which we'll talk about, and then autoimmune conditions. All right. So there's no classic presentation for the vignette here. You're going to see epigastric pain, especially after a meal. And then the one thing that you need to do to actually diagnose this is do histology / get a biopsy. So what you'll find on this are mucosal erosions or an absence of those rugal folds. So because gastritis is the inflammation of the gastric mucosa, seeing those mucosal erosions is going to be what you're going to be looking for there, okay? And then the actual cells, like the histology, you'll see epithelial cell damage or hyperplasia, okay? You can also do testing for, again, we want to see what's causing this. So you can do testing for H. pylori, or you can do immunologic markers as well. All right. So you've diagnosed your gastritis, and what do you want to do now? So if it's coming from the H. pylori, you're going to give them antibiotics, and much more on that later. If it's because of meds, just stop the meds that they're on. And really for either cause, you can give them PPIs as a protective measure for their mucosa. So that'll be good either way. Okay, stress gastritis. I thought this was like, oh, I'm stressed out for an exam, I have gastritis. Not the case. It's like body stress. So you're going to get the stress gastritis from burns, head trauma, multi-system organ failure, and then like sepsis. Okay, so you want to look out for this with like your trauma patients and then like your ICU patients as well. Okay, you can see your coffee ground emesis here and your melena. So I have like a little mnemonic here, stress gastritis. Go grab the coffee and make it a dark roast. And then of course you get the coffee runs. So this is stress gastritis with coffee ground emesis and melena. So just, it's that dark blood kind of coming out of both ends there. All right, so yeah, so with the garden variety gastritis, we had either antibiotics, like for the H. pylori, we took them off the meds, or we did a PPI. For here, the best treatment is like prophylaxis. So again, if you have that trauma or ICU patient, what they used to give is something called sucralfate or carafate. It's mentioned on the slides, although I think it says, yeah, the most recent recommendations advise against it completely. So right now, you want to give them just an H2 blocker and a PPI, kind of like your garden variety GI meds to reduce acid. All right, don't forget the names of these as well, especially the random ones like rabeprazole, which is Acifex, or like dexlansoprazole and lansoprazole. Remember, those are all your PPIs. I doubt we'll see Tagamet cimetidine again, but it is an H2 receptor blocker. Famotidine Pepcid is going to be the big one there. So just to remind you of the names, do have a little mnemonic here, but I don't really know that that's necessary for this one. Okay, so peptic ulcer disease. This can either be gastric or duodenal or duodenal, depending on how you want to say it. And the definition is going to be a break in the GI mucosa greater than 5 millimeters with a depth to the submucosa. So it's a 2-part definition there. All right. The causes are kind of the same as gastritis. It's your meds, it's your NSAIDs, aspirin, steroids, or it's your H. pylori. Okay. There is some big vignette stuff here. So just in general, you're going to see words like burning or gnawing abdominal pain. You're going to get a vague, achy hunger pain. It's going to be epigastric, but it can be right of midline. And it just becomes constant after a while. So I think of like Katniss from the Hunger Games, like hunger pain, Hunger Games. She did like a Pepsi commercial. So peptic ulcers, hunger pain. You can just put those two together. Okay, so real quick, just comparing the two. There's gastric ulcers and there's duodenal ulcers. Okay, gastric tend to occur later in life, from the 50s on. That's why I have this woman here. It is less common, and I think of that because less common, like more rare, it has a higher incidence of cancer. Okay, so the gastric can cause gastric carcinoma. For this one, you're going to get pain after eating pretty quickly, like within an hour to 2 hours after eating, you're going to get the pain because it's going to hit the stomach first. We'll learn with duodenal, it comes a little later. You're going to get melena and hematemesis. I think I'm saying that wrong, but you're going to get both of those there because of you're going to get the dark stool, and then you're going to get bright red blood through the vomits. You're going to get both of those two things. Okay. It is silent and like asymptomatic. So there's really not a lot of symptoms there. Okay. For duodenal, you're going to get melena as well, but you're going to get hematochezia. The way I think about this is because the duodenum is distal from the gastric tract, like everything's going to be coming out the back end. But for gastric, you are going to have some blood coming out through the mouth as well in the emesis. So that's just kind of how I think of that. Duodenal is going to be more common. Okay. Mostly, obviously, they occur in the duodenum, but mostly in the very first portion of the duodenum. So right after like the pyloric sphincter there. These are going to be rarely malignant. They're usually pretty small, so less than 1 centimeter, very well demarcated, and they can be very deep. The big thing here, this is definitely going to be a question, is a duodenal ulcer awakens you from sleep. So I think of like Monsters, Inc., Mike and Sully, awaking you from your sleep like a monster. So duodenal ulcers, they're more common, they are rarely malignant, and they're going to awaken you from sleep. So there's one question you just got right there. Okay. And then kind of on the other side, in terms of mnemonics I have for gastric ulcers, like the elderly stepping on the gas. So it occurs later in life. The pain after eating happens quicker. So stepping on the gas for gastric. And then it can cause cancer as well. Okay. All right. Complications of peptic ulcer disease. There are 4 of them. It's GI bleeding, perforations, and gastric outlet obstruction. So let's talk about those. Let's see. Yeah, so the most common is going to be GI bleeding. 20% of patients will just bleed really with no warning signs. Second most is going to be from perforation. This one is going to require surgical management because something is open inside of you and all this free air is coming out. So if you have somebody with these complaints and they give us an x-ray or something and we see free air, it's going to be a perforation from peptic ulcers. Okay. The third and least common is gastric outlet obstruction. We will talk about that a little later as well. All right. So again, the vignette here, you have a 75-year-old NSAID user presenting to the ED with burning or gnawing pain described as vague, achy hunger pain. That is epigastric. It becomes constant and worsens an hour after eating. So all the alarm bells are going off. This is going to be a gastric ulcer, okay? This is the one that can cause cancer, so we want to rule that out. So we want to do an endoscopy here. What we see on endoscopy, if it's benign, it's going to be smooth and regular with rounded edges. It's going to be flat. Malignant, thickened or irregular. As soon as you see the word irregular, you should think malignant. All right. It's going to be an ulcerated mass that protrudes into the lumen. Once we're done our workup, we actually want to repeat the endoscopy to ensure healing. So after we do treatment or whatever, we want to do that again to make sure that it's healing. All right. So the other cause of ulcers, or some of the causes, are the NSAIDs and H. pylori. So let's talk about each of them. So let's talk about NSAIDs. So our gastric mucosa has a high level of prostaglandins, and these things are pretty awesome. They regulate the release of bicarb, which we know is an acid buffer. It's going to raise pH and mucus as well. It's going to inhibit parietal cell secretion, so it's going to decrease acid, and it's just going to maintain mucosal blood flow. So we want prostaglandins in our GI tract, okay? And they're in charge of gastric epithelial defense and repair. But what we also want to know is that they're part of the inflammatory response, okay? So cyclooxygenase, which is COX. This is also pretty awesome because it controls prostaglandin synthesis. So again, cyclooxygenase, COX, COX, synthesizes prostaglandins. But here's the deal. There are two types of COX, okay? COX-1 is the ones that are found in our GI tract. So they are prostaglandin factories. They live in our GI tract and our kidneys. They're humming along, popping out prostaglandins like crazy. All is great and good in the world. The problem here is that there's also COX-1's brother, COX-2. This is the one involved in the inflammatory response. So COX-2 lives in our macrophages, our leukocytes, and our immune system, okay? So COX-2 is just waiting for some type of stimulus to kick into action. When we get sick, COX-2 lights up, starts spitting out prostaglandins like crazy. When we take an NSAID, an anti-inflammatory, it's going to shut off cyclooxygenase. The problem is that it's shutting off COX-1 and COX-2. Now, we want it to shut off COX-2. We're sick and we're feeling achy and we're all inflamed and our immune system is going crazy. So we take an NSAID, it knocks off COX-2, COX-2 stops secreting prostaglandins, and we feel better. That achy, sick response goes down. The problem is that COX-1 is just chilling in our GI tract, protecting us from acid, and all of a sudden it can't create its prostaglandins. So the problem with NSAIDs is that it shuts off both COX-1 and COX-2, okay? That is why NSAIDs hurt our GI tract. Hopefully that makes sense. Yeah, we can skip through this. Okay, so with NSAID-induced peptic ulcer disease, you know, a prior history, if it's happened before, it's bound to happen again. Obviously, if you're taking NSAIDs for a long time, the elderly are really chronic offenders here, so over age 75. And if you're taking NSAIDs, you also don't want to combine them with some of these other things. This could totally be a farm question. Don't mix them with steroids. If we're giving them a non-steroidal anti-inflammatory, we don't want to give them a steroid as well. We want to avoid anticoagulants or clopidogrel. So if we're already putting them at risk for ulcers, if they're already on something that's going to make them bleed or stop them from clotting, then we don't want to combine those. SSRIs, so look out for those. And then biphosphonate meds for osteoporosis, like alendronate. What do you think a lot of people over the age of 75 are probably going to be on? They might be on that medication. So look for that combination. Okay. If they do have peptic ulcers because of NSAIDs, just take them off the NSAIDs. We can also give them a PPI. And since they're older and they might be on like a Plavix, you want to use pantoprazole. That's like the go-to anyway, just because it doesn't have a lot of interactions with other drugs. Okay, let's talk H. pylori. So talking about H. pylori, we talked about NSAID. So H. pylori is the other cause of both gastritis and peptic ulcer disease. Okay, H. pylori, Helicobacter pylori, is a gram-negative urease producing bacteria. So urease neutralizes pH around the bacteria, okay? H. pylori, which is not an invasive species, it just kind of chills in our gastric mucus layer. So it does not invade the cells. It simply just makes the mucosal layer more vulnerable to acid damage and ulcers. H. pylori is transmitted in the fecal-oral route. And you're going to see this in developing countries, domestic crowding situations, unsanitary living conditions, etc. And it's pretty nasty. It has associations with chronic gastritis and PUD, which is what we're talking about now, and then cancer, gastric adenocarcinoma, which I believe is the most common, and then gastric malt lymphoma. So you definitely don't want any of those. And because of those cancers, H. pylori is totally a group 1 carcinogen. So I put that bold in purple here. It's a group 1 carcinogen. Okay. Depending on where it's located will kind of define what happens. This could totally be a question as well. If it's located in the antrum, kind of at the bottom of the stomach, it's going to cause duodenal ulcers. If it's what's called pangastritis, if it's just everywhere, it's going to cause a malt lymphoma. I like to think of like a malt milkshake being spilled on a wall. So if your entire wall is covered in H. pylori, this pangastritis, then it's going to be a malt lymphoma. If it's found in just the body, just the corpus, you're going to get gastric ulcers, but you're also going to get those adenocarcinomas. So let's see what I wrote here. You work for a corporation, so corpus, and are just another body, so it's the body of the stomach, in the endless grind for a paycheck, and you just keep saying, I don't know, 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 adenocarcinoma. So there you go. All right, so how are we going to diagnose H. pylori? So you can get a biopsy. However, doing that is invasive. So there are three better options, really two. The first thing you can do is a urea breath test. So H. pylori secretes urease, which breaks down urea. The byproduct there is CO2 and ammonia, but the CO2 is what we can actually pick up on breath samples. This is a great test because it's quick. It's 15 to 20 minutes. It has a low amount of false negatives. You do want to make sure you take your patient off of PPIs and antibiotics for 2 weeks before this test. And this one can ensure an eradication after the treatment. This serology for H. pylori, she said it's hot garbage. Just don't do it. Avoid it at all costs. The greatest thing you could probably do is a stool antigen test. So this is not only good for establishing the initial diagnosis, it can also confirm eradication. So you could do a stool antigen first, do your treatment, and then do it a second time, and you can confirm eradication. Urea breath testing, I believe, really is just going to ensure the eradication, okay? Same thing for stool antigen. Take the patient off PPIs and antibiotics for 2 weeks. All right, so now that you finally have your diagnosis, oh geez, there are two options here, and then there's like a new school option, all right? And we're not gonna miss any farm questions on this exam. So let's drop acid and talk about British rock bands from the 1960s. Okay, so real quick, so there's two major avenues we can go. We can do the bismuth quadruple therapy, or we can do the clarithromycin triple therapy, or there's like this kind of new school Talicia, which we'll talk about in a second as well. Okay, let's talk about bismuth. All right, so this is the bismuth beetles because the beetles start with a B, and they're also a quartet. There's 4 of them. So let's walk through it. There's 4 meds here. The first one is bismuth. All right, it's the most famous quartet of them all, the Beatles, and they mean bismuth, okay? They're all wearing their fancy coats. So bismuth, it's going to coat the ulcers and erosions. It's great, we love it. Second here, you know they're waving that British flag. So metronidazole or Flagyl is our second med here. And you know that these are working against anaerobes, just so you know, like the function behind it. But the big part here is that when metronidazole Flagyl gets absorbed, the byproducts of metronidazole actually breaking down, that's what actually kills the bacteria. So that's the important part of the mechanism there. A big thing here, don't drink alcohol and wave this flag and wave your Flagyl, because it's going to cause what's called an antabuse reaction. So this is actually something you can give people who are withdrawing from alcohol, because if they try to drink, it's going to make them vomit. So don't combine the bismuth quadruple therapy with alcohol, specifically because of metronidazole, because of Flagyl. That totally can be a question. The third part of this is tetracycline. I just remember tetracycline. Tetra means 4. This is part of the quadruple therapy. All right. The mechanism there is that it inhibits protein synthesis. And then it's pregnancy category D. So if we're talking like pregnancy in terms of this therapy, probably not a good idea because it's pregnancy category D. And then the fourth part of this quadruple therapy is just a PPI. So again, it's bismuth. It coats the ulcers. It's metronidazole. Once that's broken down, it starts attacking the bacteria. Tetracycline, another antibiotic here. And then just a PPI just to reduce the acid. Now, there's another part of this. If we want to combine 3 of these meds, the bismuth, the Flagyl, and the tetracycline, you can use something called Pylera. Pylera sounds a lot like Paul, and Paul McCartney was in the Beatles. So Pylera goes with the bismuth quadruple therapy, but it combines bismuth, Flagyl, and tetracycline. And then you just throw on the PPI of your choice, and you have that therapy. Okay. Now let's talk about the British rock band Cream. So this is going to be the clarithromycin triple therapy. All right. So the British Rock Trio Cream just dropped their new single, and it's called Clamp. So it's CLAMPP. This stands for, so CL is clarithromycin, AM is amoxicillin, and PP is a PPI. Okay, so it's the triple therapy. So clarithromycin, also known as Biaxin, it inhibits protein synthesis. It has a pretty gnarly interaction with statins, so you want to be careful there. It's pregnancy category C, so not great, but if you had to choose between both sides, you'd probably go with this one. You can also think of C for clarithromycin to help you remember it's category C. The important thing here is that there's resistance starting with clarithromycin. We'll talk about what we're doing about that in a second. Okay, the second part is amoxicillin. So again, clamp is kind of your cardinal mnemonic here. So the second part is the AM, which is amoxicillin. If the patient is allergic to penicillins, you can bring in Flagyl. You can start waving the flag on this side too, because Cream was a British band as well. All right, but amoxicillin is your go-to. And then again, throw in a PPI. If you want to combine all three of these, it's called omeclamox. So clam is right in there. So if you think of this clam mnemonic, omeclamox, and it just combines omeprazole and cla for clarithromycin and mox for amoxicillin. So it's literally combining all the names with the PPI omeprazole. Okay, or now we talked about this clarithromycin resistance. So we have Talicia, who I think of like this is the MC for this battle of the bands. She's the new singer on the block, and she's battling that clarithromycin resistance. All right. So this is, looks like it's omeprazole, amoxicillin, and rifabutin. So she's hitting them sweet riffs with rifabutin, which actually is a tuberculosis medication. So if we think, if we don't want to do the clarithromycin because of this like resistance, we can put them on Talicia, which again is omeprazole. So we have the PPI, we have the amoxicillin in there as well. And then we're taking out the clarithromycin and we're putting in rifabutin. All right. So those are our three insane med regimens for H. pylori. Okay. The last topic for this first PowerPoint is Zollinger-Ellison syndrome. All right. So this is a severe peptic ulcer disease secondary to a gastrin secreting tumor. It's kind of like a neoplastic syndrome, where there's like a tumor it reminds me of like the tumors that spit off like PTH and have to do with calcium and stuff. So it's basically doing that, but with gastrin. So it's just putting a crap ton of acid in our body. The main tumor is just going to be called a gastrinoma, and it primarily originates in the pancreas in something called the gastrinoma triangle. Okay. So yeah, you will have hypergastrinemia. All right, so this gastrinoma triangle, this picture is like wild, but just memorize these. This is probably going to be a question. So superiorly is just going to be the ducts. So cystic duct and the common bile duct. Inferiorly is going to be the junction of the second and third portion of the duodenum. And then medially is just the neck and the body of the pancreas. All right. Most tumors here are considered malignant. This was a hidden note in the PowerPoint, but it said that 50% of patients present with diarrhea. So you could potentially look for that on a vignette that's pointing you towards Zollinger-Ellison. And then looks like that was on another slide as well. So just remember diarrhea for that. There's also something called MEN1 syndrome, or multiple endocrine neoplasia type 1 syndrome, that has to do with this. So MEN1, Zollinger-Ellison, sure. So how do we diagnose this? This is important. An initial test you can run is called a fasting gastrin level. Nearly all patients with Zollinger-Ellison syndrome have this elevated gastrin level because that's what the tumor is doing. But patients with H. pylori can also have elevated gastrin. But with ZES, the level is going to be like much higher and greater than 1,000. So greater than 1,000 for a fasting gastrin level is virtually diagnostic. If for whatever reason you're suspecting Zollinger-Ellison and your fasting gastrin comes back normal, you can run a secretin stimulation test. So patients will have high serum levels of gastrin following an infusion of secretin, because secretin causes a release of gastrin from gastrinoma cells. We'll talk about this in a bit, but so we talk about this with fat malabsorption, and we learn that secretin enhances the bicarb secretion, which raises the pH. And a more basic, higher pH is what we need for fat reabsorption. So how I understand this is that if we give somebody secretin, it's raising the pH. The body kind of recognizes this, and these gastronoma cells start spitting out all of this acid, which will bring the pH back down. So that's, I think, kind of the pathophysiology behind this. All right, so we can do an endoscopic ultrasound or something called a triple phase CT or an MRI just to look for this. It's going to most likely be in that gastronoma triangle. To treat this, because it's just all of this acid, a large dose of PPIs. So large dose of PPIs, and then you can resect the tumor and control any metastases. That's it. That's it for the first one. So let's go right into other gastric disorders. So we're going to hit hiatal hernias, gastroparesis, gastric outlet obstruction, and gastric cancer. All right. So hiatal hernias, they can predispose you to GERD. There's two types, and you should definitely know the difference. So the first one, more common, it's the sliding hernia. So more common, like a slide at a playground. It's going to result from the widening of the laxity or widening of the esophageal hiatus from the laxity of the phrenoesophageal ligaments. So just think like phrenic nerve, diaphragm, it's kind of right there. It's sliding through there. It's more common. It's going to be contained within the posterior mediastinum. You're going to be doing a barium swallow to diagnose both of these. Treatment really isn't important for this. Do a give them a PPI if you want, or you can do surgery if it's large and symptomatic. Type 2, which is paraesophageal, and then there's like a type 3 and a 4, which are just variants, but those are less common. But just know that the second type are paraesophageal. These can be complications from prior surgeries, and they can also be associated with the abnormal laxity of these two ligaments. This could be a question. Get the gastrosplenic ligament and the gastrocolic ligament. They both start with GG. So I think a paraesophageal, like parachuting into a drop zone of a video game, and you just say good game. So para, GG, it's those two G ligaments, gastrosplenic and gastrocolic, that have to do with this type of hernia. And you can see the picture is actually pretty important here. Sliding, like the whole thing just kind of balloons out. Paraesophageal, para next to the esophagus, it balloons like next to it. So looking at that picture, just so you can see what that looks like. There's an increased risk of volvulus here. So the actual stomach can get cut off. And this one requires surgical intervention. So paraesophageal, you're parachuting in to do your surgical intervention. That's going to be the more serious one. All right, let's talk about gastroparesis. So there's things called the interstitial cells of Cajal or Cajal, and these are actually the pacemaker cells within the stomach that move boluses along. That's pretty cool. All right. And there is all right, so the definition of gastroparesis, it's an objectively delayed gastric emptying without any mechanical obstruction. So if you have a mechanical obstruction, you cannot have gastroparesis. That's in the definition. It's going to be more common in women, more common in diabetics. And then these four meds, opioids, tricyclic antidepressants, calcium channel blockers, and cyclosporin, which is like an immunosuppressant, those can all cause gastroparesis. So opioids, tricyclic antidepressants, calcium channel blockers, and then cyclosporin, which is an immunosuppressant. Okay. Three big symptoms are nausea, vomiting, and abdominal pain. I mean, they're very, very vague for GI stuff, but there you go. You do want to make sure you exclude a mechanical obstruction to make this diagnosis. So you get something called a scintigraphic gastric emptying study. So we want to know, is your gastric emptying delayed? How slow is too slow? This is important. So delayed gastric emptying is defined as gastric retention of greater than 10% at 4 hours. So if I eat a cheeseburger and more than 10% of that cheeseburger is still existing in my stomach 4 hours later, I have gastroparesis. Or 2 hours later and more than greater 2 hours later and greater than 60% of that cheeseburger is still in my stomach, I have gastroparesis. Okay. So think of like 10-4, like on a radio, like 10-4, good buddy, slow down. It's 1962. So 60 and 2 and 10 and 4, whatever. All right, to treat, we want to see if it's diabetic. We can get their blood sugar under control because nerve damage from high blood sugar can cause this. If their thyroid is out of whack, we can get it under control. Obviously, if they're taking opioids, they should not do that. There is a med here. This is a really easy farm question. It's going to be Reglan, which is metoclopramide. We learned about this in the last exam. This is that prokinetic, and it's first line for gastroparesis. But don't forget the side effects of the hyperprolactinemia, which is probably less important here, and the QT interval prolongation. So make sure you give somebody a baseline EKG before you give them Reglan. And even more important, because if they have nausea and vomiting, we can give them Zofran as well, which can also cause QT interval prolongation. So if you're giving them both of them, get an EKG. All right, now let's talk about gastric outlet obstruction. You'll see why I'm laughing shortly. Okay, so remember, this isn't a bowel obstruction. This is a pyloric gastric outlet obstruction, okay? 50 to 80% of these are attributed to malignancies. So either a distal gastric cancer, like an adenocarcinoma, and is that what we did talk about adenocarcinomas? We did talk about them being more, gastric ulcer, corpus, just the body, it's whatever. Just trying to make it all make sense. It doesn't always make sense from PowerPoint to PowerPoint. Okay. You can get a gastric outlet obstruction from acute peptic ulcers and also from chronic peptic ulcers as well, which will give you some tissue remodeling. Gastric outlet obstruction was our third and least common complication of peptic ulcers. The first two were GI bleeding, and the second was perforations. Okay, so because 50 to 80% of these are attributed to malignancies, you're going to find some lymphadenopathy. So you're going to find Virchow's node. That's going to be on the, they're going to be specifically on the left supraclavicularly, or you're going to see Sister Mary Joseph's nodule. We learned about that in the abdomen. Be right back. Okay, so because we need to distinguish a mechanical obstruction from gastroparesis, because the symptoms are similar, we're going to go straight for a CT scan. All right, and that's going to show gastric distension and retained contents. Okay, the treatment for gastric outlet obstruction, it's going to be in order of NPO, so nothing by mouth. You're going to do an NG tube to do gastric decompression, and then you're going to do IV PPI. Okay, there's other stuff too, like stenting, chemotherapy, balloon dilation, but the big three, because she has it in this box here for goo, is NPO, NGT, PPI. So why I remember this, or how I remember this, is so I'm Italian, so like, someone in my family being like, goo, you got the goo, no food, nose tube, IV PPI. So again, so NPO, NG tube, and an IV PPI. I've been saying that like all day. You'll never forget that. So that's the treatment for gastric outlet obstruction. You got the goo, no food, nose tube, IV PPI. Oh, this is ridiculous. Okay, pyloric stenosis. So this is here because it can lead to a gastric outlet obstruction. This is kind of the one you're going to see in kids. The definition is actually a hypertrophy of the pylorus. It's going to be common in preterm infants and firstborn children. Okay, some risk factors here: maternal smoking during pregnancy, early bottle feeding in the first 4 months, macrolide antibiotics either given to a baby less than 2 weeks, or if the mom uses this later in pregnancy, or just genetic. Here's like a big vignette. So you have a 3 to 6 week old who develops postprandial projectile non-bilious vomiting. Before 12 weeks is huge. Like all of these are seen before that. Okay. And a classical physical exam finding is going to be olive-shaped mass in the right upper quadrant on the edge of the rectus muscle. So that's going to be that hypertrophied pylorus that you're feeling. You're also going to see visible peristalsis. So definitely there's going to be a question about that. You want to do an ultrasound because this is a baby, and look out for hypokalemia on labs. I remember this. It's like a baby vomiting up banana baby food. So like bananas have a lot of potassium in them. So hypokalemia is going to be an indicator. And then also icteropyloric syndrome with an elevated bilirubin, which I think is just like baby jaundice, but icteropyloric syndrome with a raised bilirubin. The treatment is going to be something called a Ramstead pyloromyotomy. So they're kind of, I think they kind of like cut it and like rewrap it or something. Just remember, a Ramstead pyloromyotomy is the treatment for pyloric stenosis. Okay, so gastric malignancy, we're going to move on to. So this is no good because patients present very late in their course. We're going to see this more in Asia and South America. And this one can actually come from carcinogenic substances as a byproduct of meat and food decay. So improper refrigeration is going to cause this, as well as H. pylori, because remember, it's a group 1 carcinogen. 95% of all stomach cancers are adenocarcinomas, but others exist, like the MALT, which we talked about, if it's that pan-gastritis in the whole wall. We want our treatment to be aggressive here. And again, remember, 50 to 80% of cases of gastric outlet obstruction are attributed to malignancies. Okay. So we talked about the Sister Mary Joseph's nodule and the Virchow's node, but we're going to talk about two more here. Okay, so one is called a Leser-Treylat sign. This is a sudden appearance or increase in number and size of seborrheic keratosis. So it's like itchy moles, which are normally benign, but if you start getting a bunch of them and they're getting larger and they're getting itchy, then you have stomach cancer. And then malignant acanthosis nigricans is the other one. Okay, here's my crazy mnemonic for this. So the Grinch had a small heart, right? Well, he also had a stomach that was way too big. He sadly had gastric cancer. I mean, think about all the nasty food he probably eats, just teeming with H. pylori. And I think we learn about this later. But in addition to like pickled veggies and salted fish and smoked meats, which is all going to contribute to this, he has a huge gut and he notices something in his belly button. So that's the Sister Mary Joseph's nodule. He notices his dog Max is hungry and he only has one big bag of puppy chow left. So he takes this bag of puppy chow, slings it over his left shoulder because it's the last bag he has left. So this is that Virchow's node, which is on that supraclavicular on the left side. Okay. Then he goes down to Whoville and he sees a lit Christmas tree, lit treelat, as it's the laser treelat, and he burns it down with a laser. So that's laser treelat. See, because the Christmas tree gives him itchy moles all over his skin. That's that seborrheic keratosis with pruritus. Now, all of Whoville is completely dark. So the Christmas tree's out. This is that malignant acanthosis nigricans. And this is just like a darkening of the skin. I think you get it on your neck, but that's just like a darkening of the skin. So he notices the green of his fur is getting darker. So those are the 4 physical exam findings of a gastric malignancy. Definitely going to be a question on that. Okay, almost done here. So the strongest risk factor for gastric cancers is H. pylori infections. And the actual path behind this, here we go. So the other big risk factor is a diet in pickled veggies, salted fish, and smoked meats. And also, and the reason is because they have a concentration of nitrates, which are converted to carcinogenic nitrites. That is why, that's why this is a problem. There are some genetics here. So there's a CDH1 mutation that was mentioned, previous gastric surgery, the Billroth 1 and 2. I don't know that this stuff is as important. Survival rate's not bad. If we catch this early enough, it's a 60 to 90% survival rate within 5 years. Obviously, it does present a lot later than that. So stage 2 and stage 3, if we do a curative resection, 5-year survival rate's only 10 to 30%. Okay, so now we're going on to 3, which is upper GI bleeding and foreign body ingestion. So we know hematemesis is vomiting up blood. And if it's bright, it's a moderate to severe bleed. If it's coffee grounds, it's more limited or older. And then obviously if it comes out the other end and you have melena, that black tarry stool, 90% of the time, it's going to be proximal to the ligament of Treitz. If you have hematochezia, usually that's associated with a more distal bleed. But if it's a brisk upper GI bleed, it can still be bright red. Okay, so 60% of patients with upper GI bleeds have had one before. There is something called an aortic-enteric fistula after having an aortic graft, where the aorta actually bursts into the GI system. You definitely don't want that. It can cause GI bleeds. Just know that. Okay. Meds can cause this too. Aspirin, biphosphonates. Again, that's your like alendronate for osteoporosis, your tetracyclines, which I believe is, tetracycline, doxycycline, Plavix, Coumadin, the blood thinners, antiplatelets, aspirin, things that cause ulcers. So definitely do your due diligence in asking the question. Another kind of thing that could be a question is if a patient is taking bismuth or oral iron, it can turn their stool black and be confused with melena. So be on the lookout for that. For an upper GI bleed, definitely look for clues of hemodynamic instability like hypovolemia, which can come across as a low blood pressure, resting tachycardia. All right, you're going to see those in your brisk bleeds. There's also ascites, palmar erythema, red hands, and telangiectasias, which is widened blood vessels. I think that's the stigmata of liver disease. So that could mean this is something coming from the liver. And then if they present with severe abdominal pain, rebound tenderness, or guarding, you can consider a perforation. All right, so your patient's bleeding from somewhere. Run some labs. So run your hemoglobin and see how bad is this bleed. Run your platelets. Is there a clotting issue somewhere? LFTs, is this coming from the liver? PTINR, is there anticoagulant out of whack? Imaging generally isn't warranted, but if you do suspect a perforation, do an X-ray. Okay, if they are hypovolemic, give them fluids, run an IV PPI. Again, pantoprazole is going to be the one there. And that's actually going to reduce the rate of bleeding. So if this is from, some type of ulcer, it's a GI bleed. So, it's some type of ulcer is not going to help. So give them the PPI and then hold any anticoagulation therapy as well. We don't want to make their blood even thinner. All right, we do want to you can do an upper endoscopy to see where the bleeding is coming from. And this was a clinical pearl, so this will be a question. So you can do a nasogastric tube with a gastric lavage. So I guess you're like sucking out the stomach contents, clean it out, flush it out, pump it and clean it. If they're, if they're bleeding into their stomach and they're digesting blood, it's just a hot mess, pump it out and clean it. So other than that, how we're actually going to treat it depends. We can burn it with electrocautery. We can hit them with epinephrine, which remember is a vasoconstrictor. We can do something called an endoclip, which basically pinches like two areas of tissue together, or we can do a band for variceal bleeding. Okay, so let's talk about Mallory-Weiss tears. These only make up 5% of causes of upper GI bleeding, but they happen. Big thing on the vignette here is going to be forceful retching, where you vomit, it's fine, you vomit, it's fine, you vomit, it's fine, and then you vomit and suddenly there's blood. So the big vignette hint here is non-bloody emesis preceding the hematemesis. I know I'm saying that wrong. Hemodynamics are usually intact here versus something like varices. All right. On an EGD, you're going to see a longitudinal mucosal laceration or a red crack. Definitely going to be a question. So a longitudinal mucosal laceration or a red crack, it is a Mallory-Weiss tear, if the vignette isn't already clear with how they were vomiting earlier, okay? Most of these actually just heal uneventfully within 24 to 48 hours, all right? If they are actively bleeding, you can cauterize it or give them epi. PPI, not well studied, you can give that to them as, if you want. And it's not just forceful retching. You can also get this from lifting, coughing, blunt trauma. So Could be a vignette with like somebody coming from the gym, vomiting blood. You know, that's definitely a possibility. Okay, so esophageal varices. So these are going to be, so we've heard about these quite a bit. So these are the abnormal enlarged veins in the esophagus from that buildup in portal hypertension. Remember, it's that left gastric vein that is contributing here. And the most common location for these is the gastroesophageal junction. So the GEJ, again, it's all about that lower third of the esophagus. And here it is. Yeah, there it is again. That's where the veins have the thinnest walls, I believe. So that's where hemorrhages are going to happen. So you're going to have the hematemesis, like a lot. You're going to have a lot of bleeding. You're going to be throwing up a lot of blood. You're going to have melena or hematochezia, so just blood everywhere. But you also want to look out for hypotension. So look out for that hemodynamic instability here, again, with some tachycardia. There could be dizziness. There could be syncope. There's another thing. This wasn't in the PowerPoint, but I think she mentioned this in class, called a red whale sign. So if you see a red whale sign on an EGD, it's going to be esophageal varices, okay? Vignette is going to be 56-year-old male with a past medical history of chronic liver disease, cirrhosis. He's got hep C, presents to the ER because he's vomiting blood. Here's the big thing. He had some nausea and he immediately vomited bright red blood mixed with clots. And his wife estimates that it was 3 to 4 cups of blood. We only have like 20 in our body. So this guy is vomiting up like a quarter of the blood. So this is crazy. So look out for that. Yeah, his BP is 90 through 48. So he definitely has esophageal varices. If it's an acute bleed, we're going to give him something called octreotide, which is also known as sandostatin. It's a vasoconstrictor and it diminishes blood to the portal system. It's going to reduce that variceal bleeding, okay? I do have a mnemonic for this. So through a hyperportal, so portal hypertension, an octopus lands on the sand. So octreotide, sandostatin, and he lands on his ast. Do I have, oh yeah, because we're going to talk about labs in a second because the ASTs are going to be elevated in front of the varices. So it's a beach and there's a sea and an ocean. It all makes sense. And then he's going to play football with Blake. So portal hypertension, octreotide, sandostatin, so sand, octreotide, C's, varices. Oh, it just makes so much sense. You're also going to have an elevated AST, which we'll talk about in a second. And then this is also where you have that Blakemore tube tamponade football helmet thing. So if the bleeding is really out of control, you put this tube down their throat that goes into their stomach and you put a football helmet on their head to keep it in place. You can also do prophylactic antibiotics. And then lastly, and we're going to talk about this later when we talk about varices, and this is for more of like a chronic issue, you're going to give them the first generation non-selective beta blockers like nadolol or propranolol. Okay. That's going to, ease the heart a little bit, and it's going to, just lessen the incidence of these bleeds, lessen the pressure. Again, if we want to see if this is coming from cirrhosis, look for that stigmata of liver disease, which is ascites, palmar erythema, so red hands, and those telangiectasis. Or we can look at their labs. We'll see elevated LFTs, and we're going to see AST over ALT. The reason why I remember this is because when you drink, you fall on your AST, so AST. So heightened AST points you in the direction of an alcohol cause. You can also see an elevated INR, so thinner blood. You can also see a low level of albumin, and you can also see a low level of platelets. And if you remember, albumin is that plasma protein that keeps water in our blood. So if that's low, you're going to have fluid and you're going to have ascites. So that's something that you could look out for. It's going to point you in the direction of a liver cause here. Which makes sense because portal hypertension is what's causing this in the first place. You can also use something called a child's PUD score to correspond to increased mortality. Why is this important? Because if you, I was blown away when I read this. If you have a single episode of bleeding from varices, you have a 60 to 80% chance of rebleeding within 1 year, and a third chance of, if you bleed, you have a 1/3 chance of just dying. It's crazy. So you can use this child's PUD score. So I don't know. There's a child on the beach and in front of the seas, the varices. So child's PUD score, increased mortality for esophageal varices, or it corresponds to increased mortality. Okay, so foreign bodies. So the most common sites for foreign bodies are these. This could totally be a multiple choice question. So the upper esophageal sphincter, the level of the aortic arch, that's where pill esophagitis was happening, and the diaphragmatic hiatus. So patients, either kids or people who are like smuggling drugs, will have a sense of something stuck in their throat and some retrosternal pain, or they might not feel anything at all until they're perforated. You do not want to do a barium swallow. You cannot see fish bones or wood or plastic or food impactions. You can see animal bones. So you want to do an EGD to remove any foreign bodies within 24 hours. So I could definitely see that being a question. You need to remove any foreign bodies within 24 hours. High-risk items, your button and disc batteries. Why are disc batteries dangerous? Because saliva can cause an electric current, and then you can burn and you can perforate. Long pointed objects like a toothpick, and magnets because they can stick together and cut off a part of your GI tract. Despite all of this craziness, more than 80% of these are just going to pass without the need of any intervention. Surgical intervention is only needed in less than 1%. Okay, so food bolus impaction. We're going to have this chest discomfort, retrosternal fullness. The area indicated by the patient doesn't always correspond to where it's actually happening. You want to look out for a patient who can't handle their secretions. They'll be spitting and they'll be drooling. The treatment here, 100% a question. It's glucagon. So yes, the pancreatic glucagon. So it relaxes the esophagus. So how I remember this is it's like you swallowed some glue and like some inventor came and was like, hey, I made some glue be gone. So glucagon, glue be gone, food impaction. Just remember that it relaxes the esophagus. The most common causes of these actual impactions are esophageal webs and rings and peptic strictures. Another potential complication here is something called ischemia-induced necrosis. So a food bolus can actually exert this pressure and cause this necrosis. So if a patient presents with retrosternal pain, shortness of breath, but fever and subcutaneous crepitus, they could be perforated. Anytime you hear crepitus at all, there's air in the body where it shouldn't be. So if you see that on a vignette, it could be a food bolus impaction that's been perforated, all right? If there is a perforation, you're going to see that free air on a chest x-ray. You're going to see mediastinal widening, pneumomediastinum. She asked a question on the last exam about this. So this is definitely going to be a question. Pleural effusion, hydropneumothorax. Yeah, so maybe call somebody. Okay, one last PowerPoint for this video. And this is malabsorption syndromes. Oh, this is a lot. Okay, so lactose intolerance, fat malabsorption, and celiac disease. Okay, so saliva actually starts breaking down starches almost immediately, and then the cholecystokinin tells the pancreas to secrete amylase, and even more are broken down in the small intestine. Only 10% of carbs are going to survive until the colon. Okay, and remember, it's those enterocytes on the border of the intestine that are those functional cells, and then it's the microvilli there that are doing this breakdown. So the enterocytes produce lactase, which is a disaccharidase, which breaks down lactose, a disaccharide, which is the major carbohydrate in milk. So lactose is the major carb in milk. Infants actually have, they have more lactase to break down breast milk. When lactose is cleaved, it turns into a boring glucose and a super cool sounding galactose, which is just an isomer of glucose. Okay, So we were saying only 10% of starches get to the colon. Well, what if lactose in particular doesn't get broken down and more of it gets to the colon, where the bacteria are going to have this milk feast and cause all of this gas and loose stool? And that's where lactose intolerance comes into play. So I thought this was crazy. So nearly 80% of Native and African Americans are lactose intolerant. 80%. That's crazy. It's attributed to low intestinal levels of lactase, secondary to either mucosal injury or genetics. All right. What you want to look out here: watery diarrhea, abdominal pain, flatulence, and an acidic stool pH. Okay, we can test for this in two ways. There is the serum testing. So what do? We have them drink 50 grams of lactose, and then we check a blood glucose right now, in an hour, and at 120 minutes. If it is increased less, if their blood glucose increases by less than 20, then they are lactose intolerant. So we've given them 50 grams of lactose. If they're not breaking it down, it's not getting into the blood, the level is going to rise less than 20. It means they're lactose intolerant. Okay. There you go. Option two is we give you some more oral lactose. This is weight-based in a fasting state. And then every 30 minutes, we check the hydrogen content of your breath for 3 hours. This is also a threshold of 20, but it's hydrogen. So if it's greater than 20 parts per million, you're lactose intolerant. I don't know the exact mechanism of that. Greater, you're lactose intolerant. But there you go. Yeah, I don't know. I guess undigested lactose just gives off more hydrogen. I won't think about it too much. Okay, how do you manage lactose intolerance? Have you tried not ingesting lactose? Great, you're cured. So this is pretty patient specific. It says some hard cheese might be okay because of a lower lactose count. Butter and sour cream in small amounts might be okay also. But because your lactase enzyme isn't working, we can give you some in the form of lactase over the counter. So this is your Lactaid, your Lactrace, your Dairy Ease. And then we're also going to give you some calcium because you're avoiding foods like milk. You're going to be calcium deficient. So where else can you get calcium? Canned salmon, sardines, figs, blackstrap molasses. And you also want to do some supplementation with calcium, and then you can add in some vitamin D as well. So I believe one helps the other get absorbed. Okay, fat malabsorption. So this is a thing as well, and pH is a big part of this. Before we even start talking about bile emulsification. So gastric acids, when we eat, gastric acid release stimulates the duodenum to release CCK and secretin. Remember, secretin is what we're giving our Zollinger-Ellison syndrome patients, and then the gastrinoma tumor is going to secrete all that gastrin. But secretin by itself, and we talked about this earlier, enhances the pancreas's secretion of bicarb, which we know is a base and neutralizes the acid. It raises the pH, okay? It brings the pH up to 6.5, which is where lipase can do its thing and absorb all of the fat. So fat likes a higher pH, or lipase likes a higher, more basic pH to do its absorption. So it starts with the ingestion of fat. The stomach releases H plus and gastrin. Then the duodenum releases the secretin and CCK. And then the pancreas releases bicarb. pH goes up, okay? Pancreatitis can lead to a pancreatic insufficiency, which can lead to a fat malabsorption syndrome because it's not secreting enough bicarb, so we can't get the pH high enough. And the pancreas also can't just secrete enough lipase, which obviously we need. Here's the Zollinger-Ellison syndrome I was talking about. So this is kind of linked. All right, so we know that CCK is a big deal. It stimulates biorelease, pancreatic enzymes, and bicarb. Bile salts are important here also. the terminal ileum, so at the terminal ileum, 90% of the bile salts are reabsorbed and enter the portal circulation. So it's like they just got into a roller coaster of the small intestines, they emulsified a bunch of fat, and they got back in line to do it all over again. So bile salts are important in the breakdown of fat because of emulsification. Enzymes as well. Fats are in a strong triglyceride form until lipase breaks them up. There's lingual lipase in our saliva, and then there's pancreatic lipase. We also want to know that fat absorption happens in the small intestine. So in the duodenum, and then in the proximal 2/3 of the jejunum is where fat absorption is going to happen, okay? We want to be careful with something like a Roux-en-Y gastric bypass or like a Whipple procedure, because part of the duodenum or the entire duodenum is being bypassed, so fat can't be absorbed. So be careful with those. I did do a little thing here on like emulsification. I didn't fully understand what emulsification was. So I'll just read this. So since lipids and water don't mix, when we eat fat, it's sort of just chilling in our gastric juices of our stomach. Our saliva, the lingual lipase, did a little bit of work, but the fat hasn't reached the pancreatic lipase in the small intestine yet. Bile salts are the green guys in this picture, these little dots, and they basically break the fat up into smaller pieces. The smaller the size of something, the greater the relative surface area. That's why our cells are so small. Now that there's more surface area, lipase, which are these blue circles, can better manage all of the lipids. So emulsification is just breaking up the fat, and then lipase can come in and manage it better. So there you go. There's emulsification. Signs and symptoms of fat malabsorption: steatorrhea, so fat, greasy, foul-smelling, fatty stool that just won't flush, some weight loss, an increased measure of fecal fat. Fat malabsorption, it's going to depend on the site here. So if it's happening because of the liver, we're either going to have cirrhosis or biliary obstruction, which is going to impair bile release. We just learned how bile is going to help with fat absorption. That's where we're going to see white stool called acolic. So that means there's an absence of bilirubin bile salts. That could totally be a question. Patient presents with white stool. What's going on? What macronutrient are they going to be at risk for malabsorbing? You know, it's fat. It's fat malabsorption because they're having a liver issue. Celiac disease, which we'll talk about in a second, is also going to be an offender here for malabsorption. The pancreas, we've talked again about that. So chronic pancreatitis. You'll actually see greater than 32 grams. This is probably the worst offender. You're going to see greater than 32 grams of fat in your stool. Less than 7 is normal. And then ileum. So we talked about this as well. Resecting past the, oh wait, hold on. Let me just read what I have. Okay, a disease or resection of the ileum greater than 100 centimeters, it's normally 300 centimeters, can cause an impairment of the bile salts. Oh, it's a bile thing. Remember when we talked about bile salts going on the roller coaster of the small intestine and then getting off the terminal ileum to do it all over again? Well, if we make the line shorter and there's less ileum, not as many can get back on the ride. So when the above happens, the bile salt can't reuptake into the enterohepatic circulation. And then that happens. Be right back. Yeah, so the liver tries to compensate by creating some more bile, but it can't meet the demand. So the leftover bile salts that weren't placed back into the portal circulation have nowhere else to go except the colon, and they are thirsty, so they pull water into the colon, which is why we get watery stools. Okay, diagnosing fat malabsorption. The diagnosis is very straightforward. We're going to do fecal fat testing. Greater than 7 grams of fat in our stool is considered abnormal. Like I mentioned before, if it's a pancreatic etiology, you'll see greater than 32 grams of fat in the stool, okay? And then you can just visualize steatorrhea as well. You can do some follow-up tests. You can do a fecal elastase, which is specifically going to look for a pancreatic insufficiency. So if the question says your fecal fat test comes back and there's 35 grams. Which of the following tests is going to be the best? Well, I guess you kind of already know it's pancreatic at that point, but whatever. Just know that those are kind of connected. And then you can do celiac testing, which can be a cause here as well. So that's blood work or a small bowel biopsy. We should know the vitamin deficiencies. I put it all into Simpsons here. So if you have a vitamin A, D, E, K, these are the fat soluble vitamins. So if you don't have enough fat, you're going to be deficient in these. So A is going to give you night blindness, dry eyes, rough skin, slower bone growth, and improper tooth development. The two that I think are kind of big here are night blindness and improper tooth development. I think those are just really interesting ones. So I put pictures there for that. D is going to put you at risk for cancer, rickets, and softening of the bones. So I think of D for duh bones for this one, and that's Homer with rickets. Cancer is obviously a big one as well, so just kind of remember that with D. E is going to be muscular weakness and neurological dysfunction. So I think of E like exercise, you can't exercise because you have muscular weakness. And then the neuro one is big there as well. And then K is going to be blood clotting difficulties. Remember, vitamin K thickens the blood, which is why Coumadin inhibits it. So if we are not absorbing vitamin K, our blood is being thinned. So not a good thing. Treatment for fat malabsorption, it's going to depend on the underlying cause. So if it's of pancreatic origin, an exocrine pancreatic insufficiency, you can give them a pancreatic enzyme replacement therapy like pancrelipase, also known as Zenpep or Crayon. And then you can give them vitamin A, D, E, and K as a vitamin supplementation. Okay, let's talk about celiac disease, and then we'll be done. Okay, this could almost be its own PowerPoint. Let's try to get through it. All right, so we talked about lactose, we talked about fat, let's talk about gluten. So enter celiac disease or celiac sprue, aka non-tropical sprue, aka gluten sensitivity enteropathy. A small bowel disorder characterized by mucosal inflammation, intraepithelial lymphocytes, villus atrophy, and crypt hyperplasia. All right, so what is gluten? It's a protein complex found in grains, which make grains. So you're going to see this in wheat, you'll see it in oats, you'll see it in rye, and you'll see it in barley. They spell warb. Celiac is most common in North European ancestry. It has some genetic links, and it can just present randomly at any age. And there are technically 3 classifications: classic, atypical, and asymptomatic. Most of this is going to be about classic celiac disease. Okay. The 3 major features that define celiac disease, the big one is the villus atrophy of the small bowel. So you're going to have these like flattened, atrophied villi in your small intestine. You're going to have symptoms of malabsorption. We just talked about steatorrhea with fat malabsorption, and diarrhea and weight loss. You're not absorbing what you're eating. And then a resolution of mucosal. If we eliminate gluten foods and the issue gets better, if we get rid of gluten foods and the issue gets better, then you have celiac disease. Okay, so let's break it down. So in everyone, this happens. So this is kind of crazy, but let's try to go through it. Okay, so all right, so we eat gluten. So a bagel or some rye or something called spelt or triticale. Okay, the gluten is broken down into something called gliadin. Gliadin reaches the brush border, and our enterocytes in our small intestine, which have these special gliadin receptors called CXCR3, are kind of reacting with the gliadin. So CXCR3 is like, gliadin, what's going on? You want to try to get inside the body again, don't you? And gliadin is like, yeah, I do. And CXCR3 is like, okay, fine. Yo, zonulin, and it wakes zonulin up, and zonulin like, what's going on? And CXCR3 is like, yeah, gliadin, needs to get back in. Can we open up the gates for him? And zonulin's like, all right, yeah, but not all the gliadin, just like the cool ones. I'm only one zonulin, so I'll let a little bit of gliadin in. All right. CXCR3 receptors recognize gliadin, they produce zonulin, which open up those tight junctions, and then gliadin comes in. So zonulin opens up the gates to let some of the gliadin in the body, and normally this is no problem. Now here's the deal. In a patient with celiac disease, there are a ton of these CXCR3 receptors. So they wake up more zonulin, and zonulin goes ham on these tight junctions, and all of this gliadin gets in. That's where the problem starts. So let's walk through that. So enterocytes notice gliadin in the body on the other side of the enterocytes, and they're like, whoa, 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 how did you get in here? So they produce something called TTG. And TTG now binds with gliadin and actually changes the structure of gliadin so it can now be identified by immune system cells. So it's almost like the enterocytes like throwing a bright hat on the head of gliadin so that the body can recognize it. It's like that, hey, that's an invader, that's an invader, that's an invader. And now it's called TTG gliadin, okay? So then we have these dendritic cells, which are just kind of chilling, and they collide with the TTG gliadin, and the dendritic cell is then upgraded to an antigen-presenting cell, or an APC, okay? So the APC is like, hey, everybody, I found this, and it's holding TTG gliadin. It's like, is this something bad? And T cells come over and they're like, yeah, this is no good. This is bad. How did this even get in here? So not only is gliadin bad, but TTG is also bad. So killer T cells go back to the front lines, this brush, the brush border, and not only do they start killing gliadin, but they also are killing the TTG producing enterocytes themselves. So the body is attacking itself. It's attacking the brush border of the small intestine. So this is why in celiac disease, you have these blunted villi. That's what's happening. And then the T cells also recruit helper T cells, which recruit B cells, which produce antibody-producing B cells along with memory cells. It gets worse. So not only is there a problem with the brush border being attacked by our own body, but we have TTG other places in our body, so other cells are going to be attacked. Because that happens, so the GI complaints, diarrhea, bulky, foul-smelling, floating stools, flatulence and bloating, weight loss, nutrient deficiencies. But in other places, we're going to have issues with our bone, with our blood, neurologic issues like headaches, skin issues like dermatitis herpetiformis. So we'll talk about those. Now, there are specific nutrient deficiencies of celiac, okay? And I remember this with DIB12, so DIB12. Okay, so D, we do see this with fat malabsorption as well. And if you'll remember, think of D for de bones. So this is bone loss, rickets, osteoporosis, osteopenia. We're going to see a malabsorption of iron as well. And this is going to give us microcytic anemia. So I think of like small iron golf clubs at mini golf. So malabsorption of iron, microcytic anemia, which means the red blood cells are smaller. You can also get a B12 deficiency. This is where you get neurosymptoms like peripheral neuropathy. And this is where you're going to get macrocytic anemia. So I think of B12, B for big. So the B12 deficiency is going to give you big red blood cells. The skin manifestations we talked about, that's the dermatitis herpetiformis. These are really itchy papules and vesicles in groups. You're going to see these granular IgA deposits. So if you see that, it's going to be celiac. And if that already wasn't enough, there's a 3 to 6 times risk of non-Hodgkin's lymphoma in the celiac population and other variations with cancer as well. So it's, yeah, celiac is no good. There's a lot of issues here. So that's everything in terms of classic celiac disease, but there are 2 other types. There's atypical celiac disease. You can have minor or no GI complaints at all, but you can present with anemia, unexplained elevated LFTs. You can have epilepsy, peripheral neuropathy, arthritis, dental enamel defects, and most will show significant mucosal injury if you do like an EGD. And then there's asymptomatic silent celiac disease, no symptoms at all. This just happens when a small portion of the intestine is affected and the remaining intestine can compensate. Here's the crazy thing about this. Minor symptoms like fatigue may only be realized once a gluten-free diet is introduced. So your entire life, you've just been fatigued and you've just come to terms that that's what your baseline level of energy is. Then you eliminate gluten and then all of a sudden you have more energy. That's crazy. So if they're asymptomatic, who cares, right? Well, remember, they can get all those vitamin deficiencies. They can be at risk for cancer, can also lead to pregnancy complications. So definitely be on the lookout for that. Okay, so celiac testing, who are we testing? If it's in the family with a first-degree relative. For type 1 diabetes mellitus, type 1, we don't hear a lot about that. So that's type 1. That was even on the vignette that she gave us. Patients with Down syndrome, those with any GI symptoms or malabsorption concerns, and then all of these populations. Some of the big ones I think here are like recurrent fetal loss, low birth weight infants. So think about birth issues, recurrent migraines, and then like growing things like short stature, delayed puberty. So some pretty interesting things here. So how do we test for this? We want to make sure our patient is on a gluten-containing diet. So they want to just be eating normally, eat their gluten. So there's 3 scenarios here, and they have to do with this IgA antibody class. Scenario 1 is a normal IgA and an elevated TTGA. So remember, TTG was what we were talking about when we were going through all the pathophys. That's what is connected to gliadin and is now what in our body thinks TTG is an invader. So we're looking at those antibodies. Scenario 1 is normal IgA, but the TTGA is elevated. And we're saying probably celiac, but we're going to do an endoscopy to confirm. Okay. Scenario 2 is a low IgA and a normal or a low TTGA. This is unreliable. Can't really do much with that. Scenario 3, this is like the massive one. So if the biopsies and serologies are all normal, but we have an index of suspicion that this could be celiac, we can order a very special HLA DQ2 plus DQ8 test. Okay, if both of these are positive, your HLA DQ2 and DQ8, they might have celiac. You still don't know at this point. It's crazy. But, and this is the big thing that she highlighted, if they are both negative, the patient does not have genetic predisposition to developing celiac. So if they're both negative, that's like amazing news. You don't have it, you probably will never get it, or at least you don't have a genetic predisposition to it. So you're looking for the negative on this. How I remember this is Billy Joel with celiac, he hollered in a DQ commercial. What the hell does that mean? So celiac, obviously. Holla is like HLA, and DQ is this DQ2, DQ8. So DQ, do something different. Billy Joel was hoping for a negative test so that he could genetically test out of developing celiac. Okay, once you have a positive test, remember I said the patient might have celiac, you still have to do an endoscopy and a small bowel biopsy, okay? So I think specifically if scenario 1 comes back positive, we can then do an upper endoscopy. And we're going to look for that villus atrophy. We're going to look for scalloping of mucosal folds. I definitely think that could be a question. If you see scalloping of mucosal folds, it's going to be celiac, okay? You can also see visible fissures and then an atrophy of the mucosa. So you have celiac. What now? It's just going to be the gluten-free diet. Read your food labels. It's going to be really difficult, but do your best to get through it. There are a lot of foods with gluten and tons you wouldn't even think of that have gluten in them. You want to keep an eye on your patient's psychological well-being. And the cool thing is, if they're on this diet for 3 to 12 months, their antibodies should actually return to normal. Okay, that's 4 of 9 PowerPoints. So I will see you in the next one.